most of the definitions of fecal incontinence and various defecation disorders is already covered by the Dr. Afshan Khaja. So this session will, I'll discuss mainly the OSIS. OSIS is obstetric anal sphincter injuries. So we'll discuss what are the risk factors, prevention, and psychological impact, and try to discuss the management part. So it's already discussed, I'm not, but for continence, what are the muscles which are playing for the continence? This is for the PGs, muscles and anatomical structures responsible for the, so it's a pelvic floor and anal sphincter. Pelvic floor mein which muscle? Levator ani. Which part of the levator ani? Part of the levator ani? It's a puborectalis part of the pubococcygeus muscle which makes the sling. So puborectalis sling as well as anal sphincter complex, that is external anal sphincter as well as internal anal sphincter. So mechanism, the sphincteric, neurological. So today we'll discuss the mainly incontinence because of obstetric reasons. So now I'll come to this topic. So what is obstetric anal sphincter injuries? These are the complications that occur during vaginal delivery. So it includes 3rd and 4th degree vaginal tear, perineal lacerations, and can lead to comorbidities as including anal incontinence and RVF and perineal pain. So the reported rate of oocysts in singleton, term, cephalic and vaginal birth in England has tripled from 1.8 to 5.9%. This is according to NH data. And the overall incidence in UK is 2.9%, with the incidence of 6.1% in primary with compared to 1.7% in multi. So 3rd degree perineal tear, you all know, grade 3A, it can be divided into grade 3A, 3B, 3C. And 4th degree, what is the difference? Main difference, in 3rd degree it is external anal sphincter, and in 4th degree it's a anorectal mucosa. So in 3rd degree tear in sphincters, once the anorectal mucosa is involved, that becomes 4th degree. And in 3rd degree 3A, less than 50% external anal, more than 50% external anal, and if the internal sphincter, anal sphincter involved, it becomes 3C. And 4th degree rectal anorectal mucosa. One more thing, that is rectal buttonhole tear. It sometimes the sphincter may remain intact even with anal mucosa, and there is tear only involving the vagina and the anal rectal mucosa, that is rectal buttonhole tear. That's why it is very essential. Now I'll discuss with you that OASI care bundle which is introduced by NHS to prevent all these problems. So what are the risk factor? Asian ethnicity, nulliparity, birth weight greater than 4 kg, shoulder dystocia, occipito-posterior, you all know. But you can see that the prolonged 2nd stage of labor, you can see the relative risk is increasing as the duration of the 2nd stage is increasing. The relative risk becomes 2.2 when the 2nd stage is lasting for more than 4 hours. And another thing that is interesting, that instrumental delivery without episiotomy. It is important, that means with instrumental delivery, episiotomy should be given. So if it is forceps, there is relative risk is more than in venous delivery, and without episiotomy, it is very high, it's 6.5. With episiotomy, it reduced to 1.34. Now, to prevent this, can we prevent this uh, uh, obstetric anal sphincter injuries? NHS, RCOG, and this they have introduced the OASI care bundle. What is this? It includes 4 elements. One is, sorry, one is antenatal information for women, manual perineal protection, which we are doing. What we are doing once we are delivering, we are giving perineal support and keeping 2 finger on the occiput to maintain the flexion of the baby and allow the release of the baby, fetal head. So, this is that should be given. Third one is episiotomy if it needed. It is not indicated in all cases, but if it is needed, it should given at a right time. What is the right time for the episiotomy? So at the time of crowning, it should not be before crowning, not after. If you are giving after crowning, it may cause damage to the sphincter. So it should be given at the time of crowning. Third one is that is perineal examination after vaginal birth. That is important. Perineal examination include even per-rectal examination. That is very important, especially if it is a difficult delivery or it's a instrumental delivery. Always go for rectal examination to rule out any injury, especially rectal buttonhole tear. That can be missed, you may not be able to find. And another thing, sometimes perineum is intact and there is a tear in the sphincters may got torn. So what is the result? The study showed if they have introduced this OASI, because of there was a rising incidence of perineal tear in the UK, they have introduced this OASI care bundle, and they have shown the overall reduction in obstetric anal injuries is 3.3% to 3%. And with OASI reduced in spontaneous vaginal deliveries 0.2.6 to 2.2. And episiotomy and cesarean section rates remain unchanged. That is important. It doesn't mean you have to go for give the episiotomy in all cases, but episiotomy should be given timely as well as in cases where it is needed. If you avoid episiotomy, if it is required, it also lead to obstetric anal sphincter injuries. So what is antenatal? What antenatal care should be given to prevent this injuries? So one thing, perineal massage during last week or you can during the antenatal period, especially in the last week of antenatal period as well as in the second stage of labor. Second thing, the Cochrane review showed that the perineal massage undertaken by woman and her partner was associated with overall reduction. What does it do? It will relaxes the perineal muscle, and that is important for the delivery of the baby. So that's why perineal massage should be introduced, and warm compresses during the second stage of labor. With the warm towel can be put over the perineum to relax the perineal muscles. Third one, manual perineal protection with the head degree. You have to keep 2 finger over the occiput and keep the left hand over the perineum to sustained release of the head. And very important, this mother should not push when the head is crowning. It should not be sudden push. Don't ask the patient to push, push, push. Just it should be a sustained push. It should not be sudden. Usually the sudden birth of the head or fetal head delivery can lead to tears. So it should be prevented. And this is the time you should evaluate the patient prior this patient is needed episiotomy or not, and this time you should give episiotomy at the time of crowning. Now this once they have, these are the studies, once they have introduced this OASI care bundle, and they have shown the OSIS is reduced from 4.5 to 1.6%, the incidence, and the episiotomy rate, when there is no episiotomy with the instrumental delivery, the risk of injuries were very high. Rate of anal injury, it is a 16, almost 14%. Once they have introduced the episiotomy in all instrumental deliveries, the risk of OSIS reduced to less than 4%. So that is very important achievement. This is the introduction of OASI care bundle. Now, what is the psychological effect of the childbirth related to perineal trauma? So, Dr. Afshar Khaja has asked me to, please play this video, to share the experience of this Mrs. J, who of her birth, vaginal birth. So,
my son's forceps delivery and subsequent 3B tear happened 8 years ago. Short term, this delivery caused a great deal of trauma. My body went into shock. And even though I was repaired with emergency surgery following the delivery, I suffered PTSD and severe postnatal depression. I couldn't bond with my baby. I felt shame and a failure that my birth had left me with these life-changing injuries. Long term, I have lost normal bowel function. I suffered for several years with debilitating pudendal nerve pain before finally finding a specialist physio who was able to work the scar tissue internally to offer me some relief and improved function. Unsurprisingly, my sexual function has been greatly affected by the injuries I sustained. My muscles are weak and damaged. I have very little sensation. I'm constantly worried that my partner will leave me. Nobody ever talks about the profound effect this has on a woman psychologically. I was a keen runner prior to giving birth, and I enjoyed going to the gym 3 or 4 times a week. I have slowly got back into walking and jogging on the treadmill, but it is only ever possible by using a pessary and a tampon to hold everything in place. The question I am left with is, how did I walk into an NHS hospital to have my baby delivered and walk out the broken woman I am today? The answer isn't simple, but it should be. Had I had information antenatally about the risks of vaginal birth, which could include a forceps delivery, I would have made different decisions. Because the right for a woman to have information about what could happen to her body at birth is the same right that a woman has to bodily autonomy in all areas of her life. My salvation has been finding MASIC, and I truly believe I wouldn't be here today without the support and the hope that the charity offers.
So I think this is Jay's story, but there are so many stories, those who suffered the OSIS during vaginal birth. So the psychological and implications associated with childbirth-related trauma may be fecal swelling, urgency, incontinence, flatus incontinence, dyspareunia, depression, psychosocial sexual issues, delayed bonding with the baby, and cessation of breastfeeding. So we should first prevent. If occurred, should be managed primarily. So the repair is very important. It should not be like first repair is the best repair. That will give the maximum result achieved. It is the by the first repair. So if it occurred, it should be diagnosed and should be repaired that time only. So it should be conducted by repair of oocyst should be conducted by appropriately trained clinician, not by all. It should be by trained clinician or by a trainee under supervision, because it is the first primary repair is the very important to repair the first time. If you repair first time, there will be a the incontinence problem will be less. If you repair, secondary repair is associated with more damage to the anal sphincter, and the continence will not revert back to the normal. So should be done in OT, not in labor room. The patient should be with the good light and should be done in regional or GA. Why regional or GA? Why the relaxation is important for the anal sphincter injuries? Why can't we do just with the pudendal block? Because to approximate the anal sphincter, we require the maximum muscle relaxation. That's why the GA and spinal should be given to the patient. If there is a excessive bleeding while you are shifting the patient, a vaginal pack should be inserted. Other thing, the figure of 8 sutures should not be taken, and sutures should not be tight. They will lead to ischemia. You have to just approximate the muscle. You just don't make it too tight, because it will not, it will cause the vascular ischemia rather than rather than helping the patient. So too tight stitches are avoid the healing of the affect the healing process. So the full extent of injury should be evaluated by careful vaginal. Sometimes there may be third degree perineal tear, and simultaneously you may get sometimes rectal buttonhole tear above that apex. So the careful examination should be done to for the evaluation and to rule out any other injuries like rectal buttonhole tear. The torn and anal epithelium must be repaired with continuous Vicryl 30 sutures. And the apex of the tear is very important to take the apex. If you will not take the apex, it will lead to the later on the patient may develop fistula or incontinence. That's why the examination and the diagnosis and the first primary repair is the most important part of OSS repair. Now, internal anal sphincter, if it is a 4-degree tear, the internal anal third degree with grade C tear, the anal sphincter will be gone. So it should be repaired with the 30 PDS. PDS is polydaxon. It should be a monofilament rather than multifilament to prevent, because the monofilament there is a less chances of infection with, rather in multifilament there is a bacterial growth in the filaments with the layering of the sutures. So monofilament sutures are better than the multifilament sutures. If less than 50% anal sphincter, so there are two methods of repairing the anal sphincter. One is end to end, just approximating. Another thing is overlapping. Overlapping required more expertise than the end to end. Number two, it required more relaxation, more dissection, lateral dissection. Sometimes it may not be able to overlap. You should go for overlap. But if you are not expert enough to doing overlap method, it is better to go for end-to-end suturing rather than going for overlap. Okay, so now remember, anal sphincter would be more likely to traumatized. Another thing, the perineal muscles should be approximated over the anal sphincter, and the perineum should be created enough, at least 3 centimeters should be there, because with future deliveries, it may get further torn, and it will perineal muscle will give the strength to the anal sphincter. So good perineum with a good perineal muscle repair is the key to the success of the oocyst repair. Yeah, incontinence. As perineal muscle repair with the good perineal length. So this is end-to-end technique, this is overlap technique. Even in the grade 3 tier, you can go for end-to-end, but it is better to go for overlap if you are expert enough in doing overlap technique. So what post-operative care you required? The use of broad spectrum antibiotic is recommended. Even the NHS said the Foley's may be kept for 12 to 24 hours depending on because it may lead to retention of urine because of perineal pain. It's not there is some problem with the bladder, but because of perineal pain, patient may not able to pass urine. So even you can keep the Foley's for 12 to, but RCOG 2017 guideline doesn't that's why I have not included. But recently I have gone through that NHS paper. They said 12 to 24 hours Foley's catheter may be kept. So the use of post-operative laxative, bulking agent should not be given. Patient should be advised physiotherapy following repair, and there should be review visit should be done after 6 to 12 weeks postpartum. If the woman is experiencing incontinence and pain, they are saying that secondary closure should always be done by according to RCOG and NHS in a perineal clinic, and they should refer to the urogynecologist rather than it should be done by gynecologist. Yes. Not colorectal, it is required once it is a large fistula, if there is a need of colostomy. Otherwise, it's a urogynecologist that is enough to repair. So prognosis, women should be advised that 6 to 80% of women remain asymptomatic after good delivery. It's not 100% even with a good repair of the sphincter. So that means the proper delivering process is very important. Now what will we do with the future deliveries? If the patient develop oocysts and now she is again come to you with the pregnancy, how will you counsel that patient? So the all women who sustained oocysts in a previous pregnancy should be counseled about the mode of delivery, and it should be like it depends on the what type of problem she is having. She is symptomatic or she is asymptomatic. So if the patient is asymptomatic, that's why the perineal all antenatal women according to NHS and UK guideline they are following, they are referring to patient to the perineal clinic, and they are going for the anal manometry and endoanal ultrasound if they have sustained previous OSS in delivery. So if the patient is asymptomatic, then anal manometry and endoanal ultrasound should be recommended. If it is normal, then vaginal delivery can be suggested. If it is abnormal, then cesarean section. That means if there is a persistence of problem, then cesarean, because the normal vaginal delivery will increase the problem. And even after doing the secondary repair, it's not essential that she may relieved of her symptoms. That's why even with the abnormal finding, you should go for a cesarean section with in asymptomatic if the endoanal ultrasound is abnormal. But we are not doing all these things. It is essential because we have to take this decision. If we are not doing endoanal or all these things, I think we should counsel the patient. Should we give her a trial or should we go for direct elective cesarean section? And abnormal is like they have to measure the maximum squeeze pressure. They use the some pressure manometer. By detecting if it is less than 20 mmHg, they and endoanal ultrasound may, if they defect the is more than 1 hour, they do some method. 1 hour, it is 1 hour, like they are assessing the patient and they are doing some squeezing test for how long she is holding the flatus and feces. They are testing that. So if it is symptomatic, no, it's not only machine, it's a expertise which is required for endoanal ultrasound. Endoanal ultrasound can be done with the these transvaginal, I think, probe. Bus expertise. That's why I'm telling, if the patient, you should counsel the patient and you should go for the, according to patient choice, it is better to go for if there is a some type of abnormality she is having. She is, even although she is asymptomatic, but if sometimes she leaches flatus or sometime, you can counsel her for. Flatus has some defects. It may be occasional. That's why they are saying it's asymptomatic women. It may be occasional rather than continuous passage of. These are symptomatic patient. If patient is asymptomatic, but a normal in sphincter, but actually the normal in even after repair, even after repair, you cannot regain the normal in sphinctering function with the, even with you are giving your 100% in repairing. That's why they have introduced the ORC bundle care to prevent these injuries. If they are not heavy. So conservative, if patient is symptomatic, what should be done? If it is, even patient is symptomatic, the anal monometry or endoanal ultrasound is normal, they can go for vaginal delivery. If it is abnormal, if it is mild, cesarean section, severe may, she can go for vaginal delivery and later on repair if the family is complete. If family is सो सीवियर है तो कोई उससे ज़्यादा सीवियर होगा ही नहीं ना. एक बार सीवियर है तो पेशेंट शुड बी लेफ्ट फॉर वेजाइनल डिलीवरी एंड once the family is complete, then she should go for repair or she should go for future cesarean section if she doesn't want to. So what is there anything like occult oasis? कुछ है occult जैसा कि हमें दिखा नहीं और है इंजरीज? ऐसा हो सकता है कि हमें नहीं दिखा मगर उसे इंस्फिंक्टर की टोन चली गई, हमने बहुत. हाँ, फॉर वेजाइनल डिलीवरी. नहीं, नो, सो सिजेरियन सेक्शन शुड बी डन ना डायरेक्टली. नहीं हाँ, नहीं, दो तरह की. मैं गाइडलाइन ये कह रही हैं कि अगर इफ इट इज अ सीवियर और वो आ गई आपके पास, रिपेयर करा के आई है तो आप सिजेरियन करेंगे. रिपेयर करा के नहीं आई है तो विल गो फॉर नॉर्मल डिलीवरी और उससे कहो बाद में रिपेयर करा ले. यही है हमारे पास ऑप्शन, है ना. अच्छा, ओकल्ट ओसिस, इज देयर एनीथिंग ओकल्ट? सो this is a one large study performed by Sultan et al. And they said that 33% of women who are delivering, they sustained occult oocysts. Later they studied further. They found that these are not occult oocysts. These cases were misdiagnosed. They are not examined at the time of delivery. These all are